Hopefully doesn't turn into a political debate like we see at this time of the year on television. But the approach that I'm going to use tonight will consist of a leading question to each of the panelists. I will then give them a chance to answer. I may or may not ask follow-up questions. For the panelists, they know to take as long as they need to take to answer the question as completely as they need to. I will ask each of them several questions during the course of the evening, and then, as Alexis said, after that, I'll open it up to the floor for anybody in the room to ask any questions. That includes the sponsors that are in the back as well. Last night, I put all their names in a hat, and I drew the names out one at a time so that none of them can feel slighted of who goes first and who goes last. So the first question is posed to Dr. Shipman, because her name came out first. And it says, Dr. Shipman, could you explain to the guests the difference between the Davinci approach to your surgical procedures and the traditional laparoscopic approach?
Are we on? Okay. So traditional laparoscopy, the instruments are put in the patient, and the surgeon is actually standing beside the patient holding these long straight arms. Two big things with robotic surgery. One, it allowed the surgeon to sit comfortably at a console instead of standing with your arms up around your shoulders and your ears. The biggest advantage is the instruments have an articulated wrist. So instead of a straight instrument that you're using, you can now get in and around corners and underneath things. It gives you a lot more flexibility and mobility with the instruments. I know we're going to talk about a lot of other options with this, but just from a strictly surgical technique, it really is a wonderful tool just to give us a lot more mobility.
Okay. Thanks. Dr. Giuseppucci, you're a general surgeon who does many common operations that all of us have had the unpleasant experience of undergoing, such as cholecystectomy or removing a gallbladder. So can you map out what the difference between doing the Davinci surgery and the traditional open cholecystectomy or open procedure that you have done?
Yeah, it's interesting because what the robot gives us as a surgeon is the ability to perform the same kind of movements that we do open with all our 360 movements of our wrist and everything in a limited space and through a min-invasive approach. Meaning the surgical technique that we use is the same technique that we use in open surgery, but through small incisions, and doesn't involve the patient in the post-op.
So with the traditional approach, your incision involves more muscle damage or a larger incision?
Big enough to put our hands inside of the body and perform all the surgery through that way. We basically, once again, the robot gives us the ability to perform the same kind of movements in 1 square inch inside of the patient. With advantage in visualization, is 3D visualizations, and the abdomen is enlarged 20 times.
Thank you. Dr. Jones, could you explain a little bit of the difference between the robot that's used for total joints as opposed to the Davinci? Whenever anybody that's out there hears about robots, they always have this image that there's a humanoid type of robot that is doing the surgery. Can you explain the difference between the Mako robot and the Davinci as it applies to total joints?
Well, as they were explaining, the Davinci is like an extension of your hands doing a procedure, whereas orthopedic is more of what we call a navigation. The important part of the robotic surgery actually happens before the surgery, where we map out the bone ends, the 3D model, and then in surgery we're able to balance the ligaments and customize the knee to that individual patient. So there's a lot of stuff that goes up to it. And then what happens with the robot, it guides our saw cuts. So once we have a thing that's different, we have this array, a little like laser grid pointed at us with some little things that we put in the bone. and it tells us where to go and what to do. But instead of just cutting a knee a lot like we've done in the past, everybody gets 7 degrees, we balance out the ligaments and really customize the implant. And then the robot guides our cuts. We still have to, push the trigger, but it's a little different than the Davinci, and the Davinci is really an incredible thing where you can go in there through this little hole and do some amazing things. It's more of a planning as well as a navigation to do a more precise total joint.
And Dr. Jones, the total joints that you're referring to, is it all the total joints for the different body parts, or is there specific joints?
Generally, the two most common are knees and hips. And the advantages of the robot in those are different, but there's also, we do a navigation guidance with total shoulders as well.
Thank you. Dr. Hatahet, as a urologist who treats prostate disease, can you tell the audience the difficulty when it comes to the prostate in general and the advantages that the Davinci gives you over the previous ways of treating that disease process?
Okay, so prostate is deep in the pelvis, and every surgeon knows that this is difficult to reach. This is difficult surgical field deeply in the pelvis because we approach it from the abdomen, and it's far from the incision usually. So robotic surgery helps to reach this difficult field, and we can do the surgery very precisely with very gentle movements in this area. Also with robotic surgery, we have the 3D-dimensional camera that it can help with give the surgeon sense about the depth compared to the standard laparoscopic surgery. In addition to that, when we look through this console, it helps us to see this depth compared to watching this surgery or the surgical field in a flat screen. So having this ability helps us to see and do better and work better. In addition to that, also the pelvis working with and prostate. There's another specific thing regarding this surgery is the pelvis is narrow compared to the abdomen or other surgical fields. We have pelvic bone are very narrow, especially if we go deeper in the pelvis, and this is where the prostate is located. So the robot helps the surgeon to do whatever he want to do in this area.
All right. Thank you. Dr. Mashburn, as I stated earlier, general surgeons treat a multitude of ailments that require surgery on a multitude of organs in the abdomen. Can you tell all of us and give us a sense on how the Davinci has impacted your thought process and your approach to treating these different ailments surgically?
Okay. First of all, thank you very much, Dr. Jones. So from a standpoint of a general surgeon, being able to, as we have discussed before, being able to get into tighter spaces, being able to get into areas where we would normally be using our hands, or even with laparoscopic instruments, which are basically very long, straight sticks, but they're, for the most part, long and straight without the wrist that moves and articulates. Using this articulation technique, we're able to get into areas where beforehand it would have been very difficult for a laparoscopic surgeon to get into. I initially was trained as a laparoscopic surgeon, and I can do many things, but this has been much of a game changer. My procedures are now quicker. I can get into areas where I would have not gotten into before. I can get myself out of trouble quicker than I used to be able to get myself out of trouble as a laparoscopic surgeon. It is very much revolutionary when you do have the ability to have to use that articulation, or in other words, that wrist of that that robot. And you will see during our demonstrations that helps us get. It's almost like an intuition thing. We learn how to use our hands, and we learn how to do the wrist movements when we train in open procedures. But then when we get to a laparoscopic procedure, our brain has to think a different way. Well, what the Davinci has done is basically our brain is able to go back to more intuitive things, or more of a muscle memory. It's quicker to do these procedures, and quicker to get yourself out of, into an area and out of trouble of an area. And the three-dimensionality, as Dr. Hatahet said, it's like you're using both eyes to be able to get in to see an area because of the three-dimensionality. Thank you.
Dr. Shipman, back to you. Could you highlight the benefits of the Davinci approach for your patients in terms of return to activities, complication rate, and any lifestyle changes that have to occur as a result of what you do?
So I'm just going to talk hysterectomy right now. Traditionally, hysterectomies used to be done through an open incision. Vaginal hysterectomy also was an approach, and then laparoscopic, followed by robotic hysterectomy. The laparoscopic approach over an open incision is night and day. I have patients that leave the hospital same day instead of staying 2 to 3 days from an open incision. I've had patients go back to work the same week if they're not lifting. Pain-wise, most of my patients go home on ibuprofen and Tylenol. Physically, they're back up, moving around, walking, doing everything but lifting. The biggest thing I hear from my patients, they're still tired. Your insides still have to recover, but physically they are able to get up and move around right after surgery. They're walking, most of them are eating lunch, day of surgery, having solid food. So just a much quicker recovery, much less pain, and it gets them back to their lives much faster.
Thank you. Dr. Giuseppucci, I ask you the same question about the benefits to your
The experience
patients.
that we are seeing in our patients is they define it like it is easier to recover. I mean, they are back to the normal activities much faster than before. We prescribe much less pain medication or narcotics. As I say, we are giving patients Tylenol, and they come back to the office and say that maybe take 2 or 3 times Tylenol, and that is it. Clearly, the pain is a less issue than with open approach or with laparoscopy. Also, the length of stay in the hospital where any procedures that you do is decreased. I went into the abdominal wall reconstructions, and are a huge hernias, and we fix with the robot, and the patient spends 1 day in the hospital, go next day. All the rest of the surgery pretty much are done as an outpatient.
Okay. Well, thank you. Dr. Jones, can you point out the benefits of using the Mako to assist with the bone cuts and the ligament imbalance that you have referred to earlier than a traditional total knee or total hip replacement in terms of the alignment and the way you made the cuts prior to using a computerized mapping out of the ends of the bones?
Well, previously, you would have several devices when you would go into the knee to get your alignment, to make your cuts. Some of it is visually taking landmarks, some of it is drilling holes up into the bone to put a rod up the bone to get the angles. What we're able to do with the robotics is to be more precise, and that does really, in my opinion, 2 things. One, it allows you to be less invasive. You don't have to go and strip the whole bone off the end of the femur to make sure that the alignment guides are in the right position, or if this one guide that you would put for the thickness of the femoral cut is touching directly on the bone. you can just leave it because you know that you're not having to use that part of the bone. So you're being less invasive, which means you're not touching as much soft tissue, and you know, you can generally get up and around quicker. We're practically doing total joints as same-day surgeries. Some of them are going home that night if they're young and healthy and don't have any other factors and have some good help at home. They go home the day of surgery. The other thing that we see, because we were able to customize the cuts and balance out the ligaments, the knee feels more natural. We can never reproduce a natural knee. There's certain parts of it that I don't think we'll ever be able to make like they are originally. But by being more precise, the knee will feel more natural. It will make less noise because it's metal and plastic, so it won't click as much. And generally, people can get around and recover quicker because they're less invasive. Better range of motion initially, and of course, shorter length of stay. And if you're less invasive, in theory, you have less pain as well.
Thank you. Dr. Hatahet, as we all know as surgeons, that there is no such thing as a surgery without complications. Anytime you intervene in a patient to treat something surgically, we always have to explain to the patient that there are complications that could be realized. Can you address to the audience with the type of surgeries that you performed, how does the Davinci minimalize and change the types of complications that you see?
Usually after removing the prostate, just for cancer, not like normal just benign prostate, we remove the prostate, and surgically in anatomy, we have the prostate, and underneath the prostate there are the muscles that are responsible for holding urine. In addition to that, next to the prostate from right and left, there are the nerves that are responsible for erection. And when we remove the prostate for tumor, we need to dissect all these tissue far from the prostate and have just the prostate itself. So definitely there is kind of trauma by pushing this tissue far from the prostate. By having this technology, having this robot, we can see and act as we want. We can move the instruments, we can expect where these nerves are, we can deal with them gently instead of dealing with them instead of like just push the whole tissue. We can work more like precisely in the areas that we need to work on. And this will help to preserve more nerves if we are talking about like nerves, and also will help in preserving more muscles when we dissect the prostate. So this will cause less chance of incontinence after radical prostatectomies, and also less chance of having erectile dysfunction. It's these. I'm talking about these two complications specifically because this is like more than 90-95% chance for patients to have this complication, but usually it is reversible within 2 to 12 weeks. But with robot, definitely this is better compared to like open surgery and other approaches.
Thank you. Dr. Mashburn, the same question.
Okay. So same questions is we can really get into the abdomen. We can take a look at the blood vessels. When I'm doing a hernia repair, there is always a risk of bleeding, risk of infection, as is with every surgery, risk of injuring the tissue surrounding the area where you're working at. When you're doing a gallbladder, the same thing. When you're doing a bowel resection, the same thing. In other words, you're cutting part of the bowel. All of that does entail risk of bleeding, risk of infection, risk of injuring the surrounding structures. But when you're actually looking at something three-dimensionally with your own eyes, you know, and through the camera lens, but you have a three-dimensionality through that camera lens, as opposed to two-dimensionality laparoscopically, or even open would be much more invasive, more structures. Your hands are larger. You would have to kind of separate all these tissues more so with your hands to get to that area. But if you're doing it robotically, it's almost like using your own hands, but very, very tiny hands. And you're using and so for the most part, it's almost like using your own hands, but very, very tiny, and you can get to an area and with the least amount of tissue pressure and be able to, so in other words, it's what we call dissection. And just this spreading of this tissue is much more gentle, even more so than laparoscopically, I find, and I was initially trained in that. So.
Okay. Thank you. Dr. Shipman, last question for you. Are there any patients who you feel should not have the Davinci approach as opposed to a more traditional approach?
From a GYN standpoint, uterine size makes a big difference because I can make small incisions and do the entire surgery through small incisions, but I still need to get that specimen out. And if the uterus is too large, we're not able to remove it without an incision. Health-wise, anytime you're doing laparoscopy, and at the end of the day, robotic surgery from a GYN standpoint is still laparoscopy. We have to blow your belly up like a big balloon. That can put a lot of compromise on breathing. So somebody who's got bad emphysema, somebody who's got a lot of respiratory issues may not do as well with a laparoscopic approach. The flip side of that, somebody who has diabetes, whose wounds are not going to heal well with a big incision, does much better from the robotic approach. So anybody, patients that are a little heavier, when you're making that abdominal incision, that's a lot of tissue that has to heal, and being able to do that through small incisions makes a much better recovery.
So what conditions would lead to a larger uterus coming from a non-uterus type of person?
Fibroids are the biggest thing. People can get quite large, very large ovarian tumors as well that you may just not be able to even get a laparoscope in because the ovary is so large. But fibroids are what typically, and 45% of women have fibroids in their uterus. It's a benign, non-cancerous muscular tumor in the uterus, and they can get quite large.
Dr. Jones, the same type of question to you. Are there any patients that you feel that you should not be using a robotic approach?
There are some patients that have had severe trauma, have a lot of hardware in their knee, because you do have to be able to image the knee with a CAT scan to make a 3D model. So there are some times that people have had a lot of trauma or very significant severe deformity or bone loss. You're looking at very specialized implants, but it's very rare. The people that are limited from having something like this, or limited from having a total joint, their overall health, the amount of deformity, problems with patient size, the size of the leg, things on those lines. But generally, with as opposed to the size of the uterus, the size of the leg is mitigated by doing the robotics. It actually makes that not as much of an issue. But there are some times when there's been previous trauma, previous hardware, that it makes it very difficult to do.
Dr. Hatahet, this is a double question. Could you explain to the audience the expertise of the operative team that you require when you do the Davinci at Trumbull Regional Medical Center? And number two, since you've been to other hospitals during your illustrious career, can you comment on the members of this team here compared to other places?
Okay, so I was trained in a center with very high volume of robotic surgery cases. So the team were do this on a daily basis as well. When I came here, I also find that people are very talented and in the OR. And from the very first case I did, it was they were very quick in figuring out what I need and provide this to me, and this helped actually in providing the appropriate stuff to deal with, give me more comfort during the procedure, and help also with saving some time for the like operative time. So here in Trumbull Regional Medical Center, I would say I'm totally happy with what we have in the OR.
Thank you. Dr. Mashburn, last question before I open it to the audience. As an instructor and a preceptor for the training of the surgeons of the future, since Trumbull does have a residency program, does the use of the Davinci change the way you teach these young physicians?
Oh, it's pretty amazing to see the growth of a young physician because obviously we all learn this way. And, you know, the goal in life is to work yourself out of a job. Eventually, you train someone into being able to take over your job when you're no longer, you're too old to do this. But the beauty of this is when I am teaching a resident to do the procedure, there are aids with the robot that I can explain to them with graphics and kind of arrows on the screen, and I can stop it and you know, and kind of tell them, okay, let's go back on this side here, let's go on that side. I can also, if I'm doing the procedure myself, they're also seeing me do it, so they're actually witnessing how to do it from in there, as opposed to, because you could see the screen, and it's just a very wide screen, and so I'm doing this procedure, and I could say, well, this is a safe zone, this is not a safe zone, you don't go this way, you go this way, and you know, and it's visually, it's a much broader field to be able to show them this. So it's really amazing what Trumbull Regional Medical Center has. We are training some of our brightest physicians to be surgeons, and one day they will, you know, we're not eternal, so one day they must be able to do the same things we do and even better. So the goal is to make better surgeons than us.
Thank you. So I want to personally thank all the panelists tonight for taking time out of their private lives to come here and sit on the hot seat. So I'm going to open up the floor to any questions from anybody. You can either ask it yourself if you want to be so inclined, or if you write them down, I can ask them for you. Why don't you hand me that?